Yeah, I'll pass over to Caitlin and Sahir, who will share kind of how the social prescribing service is being evaluated in Barnet and the reporting they've developed, which kind of links actually GP data to the social prescribing data from Elemental, yeah, which is a really great example. So yeah, over to you, Caitlin.
Lovely, thank you so much. It's really great to be here today. I'm just going to introduce myself a bit further, so you know obviously how our service is run in Barnet a little bit before we get started, and then I'll pass over to Sahir, who will introduce herself as well. So I'm Caitlin Bays. I'm the social prescribing link worker manager for the Barnet team in North Central London. We have that operating through Age UK Barnet. So I have a deputy manager, and we have 24 social prescribing link workers across 7 PCNs. So quite a large team overall. I'm going to hand over to Sahir to introduce herself as well, and then we'll carry on with the slides.
Hi, thanks for the invite. I'm Seher Kayıkçı. I'm Senior Public Health Strategist from Barnet Council. My remit is mental health, neighbourhoods and communities. Hence, social prescribing comes under my remit, but I have been working on social prescribing for so many years. And I worked with colleagues, GP Federation, in setting up the social prescribing service in Barnet.
Lovely. If we just go to the next slide, that's great. So just to give you a bit of an overview of the reporting that we do in Barnet. So we use the case management system Elemental. At the moment, that's funded by the public health team and our ICB as well. And so they've been funding that for the last 3 years. And we have reporting duties that sit under myself as the SP manager and my deputy manager as well. So that sits through the Age UK Barnet, and Age UK Barnet is the licence holder for Elemental as well. So that's how that's set up for all of the 7 PCNs in Barnet. The reports go out every month and every quarter, and then annually as well. We have sort of varying different reports for those time spans. So we send the monthly reports to the PCNs. They get an individual PCN report for their PCN data set, and then also that goes to the Barnet Federation as well as Public Health and Age UK Barnet. And then quarterly and annually we also send those reports so to the PCNs, Barnet Federation GPs, Public Health, Age UK Barnet, ICB, and then the Health and Wellbeing Board gets the annual data set as well. We have a monthly presentation that is an Excel document, so that basically just goes out. Happy to share what that looks like as well today. And then we have presentation formats for the quarterly and annually, and for distributing that data set. And yeah, content wise, so the monthly is around the service utilisation, so splitting by referral numbers and then also by the practices. And then obviously the PCN total as well as referral reason and appointment information. And then the quarterly and annually include all of that, but in a bit more depth, as well as the demographics, onward referrals, so where social prescribers are sending their clients to, so signposting and referring, outcomes, feedback survey we have as well. So our outcome measures, we use our ONS as well as GP attendance. And then we also report on gaps in services, which we do through the Elemental system, and updates of the team and services and things like that for just general awareness for all of those key partners. So Jenny, if we move on. Fabulous. I'm going to hand over to Sahir to go through the public health evaluation.
So we have an annual cycle of conducting an evaluation through our public health intelligence team. The purpose of the evaluation is twofold. We look at patient outcomes via ONS 4 questions. Also, you know, as you all probably know, that it demonstrates personal well-being on the 4 outcomes: satisfaction, worthwhile, happiness and anxiety. And in addition, Caitlin also conducts patient feedback survey. We combine the two to demonstrate the patient's individual outcomes. We also look at the impact of the service on the system. We look at GP and A&E attendance. So we analyze EMIS data as well as the the elemental data. But there are some limitations of doing that. In terms of demonstrating GP attendance, we are, it needs to be done manually through EMIS, and EMIS access is limited for analytics staff, and directly employed by PCN. It's through GP Federation. Public Health doesn't have access to that data. We used to have access to primary care data, but not at the moment, since Public Health has moved to the local authority. So there are quite a lot of challenges of doing that. And when we first ran the evaluation, it was just after COVID, and that skewed the data greatly, obviously, in terms of, in particular, A&E attendance data. Not many people were going to A&E in those times. Should we move on?
So the public health evaluation is on an annual basis, and is really helpful. The PCNs find that really impactful for obviously looking at ongoing support and ongoing kind of projects using social prescribing and how we can best support patients that are in high need. So we're just going to go through a bit of the impact for the PCNs and an impact for how we share the data across the community as well. So obviously we've got lots of data sets that we can share, and obviously we have to have permission to share certain data sets with certain groups and organisations. But for the primary care networks, the biggest thing that we found really useful for the data set we were able to collect through Elemental and also from the public health evaluation is showcasing the value of the social prescribing service, which obviously at the very beginning was really important for embedding a strong sort of sense of value and need for this social prescribing offer, but as well as also having higher engagement from the primary care network. So we've been able to use data sets to be able to support having an increased number of social prescribers at our primary care network, as well as obviously supporting ensuring they have capacity and also supporting patients with the highest needs as well. PCNs use the reports, so they use them monthly and quarterly for ongoing project work. So we've been able to use the social prescribing data sets for a lot of the health inequalities projects that the PCNs have been needing to run, and also the winter pressures projects as well. So social prescribing data sets had a high sort of value for supporting that work. And then also obviously measuring patient outcomes. So PCNs are obviously really keen to hear how our feedback survey data is, how our ONS data sets are, and obviously GP attendance. And we've done varying different high frequency attending social prescribing projects to support reducing GP attendance for those that may have non-medical based needs, as an example of this, which has shown real great promise. So if we just move to the next slide. Sorry, Jenny, I don't know if you're sharing your screen anymore. Lovely. Yeah. So just on the wider impacts of the reports, so obviously PCNs use it, which is great. Our ICB use it, Barnet Federation, but what we've been really keen to do is make sure that it's available across our community and supporting with positive change across our borough. So we have obviously annual cycles of reporting that goes to the Health and Wellbeing Board, and Sahir presents at those to raise awareness of the needs and demonstrate success of the service. Obviously public health, so Sahir can comment more on this, but use this for informing the community innovation funding decision making. So funding is used where highest needs are, and that has been for the last, several years now, which has been fantastic. Social prescribing reports, so mainly annually and quarterly, are used to generate discussions to develop borough neighbourhood model. So this is the sort of neighbourhood model that's coming across the ICB, and there's lots of project work for having this embedded now, and social prescribing data is used very regularly to support that work, and also social prescribing insight from the team members as well as from ourselves and the management side as well. Obviously lots of different needs and trends are picked up and detected, and we can obviously split this using the elemental case management system for very finite locations. So we've been able to work with local commissioners on certain different projects across the last 3 years that we've had the elemental system. So for examples of that was the mental health transformation, used data sets from social prescribing. Our Health Watch team across the Inclusion Barnet use data sets from social prescribing every year to support their work, and obviously social care commissioners as well. And again, looking at sort of full quarterly data sets around either particular needs of interest or sort of overall social prescribing needs. And lastly, just an example of the work that we're picking up for our gaps. So our team previously used to just anecdotally report on gaps in the services, and then we would try and elevate that. And what we've been able to do through the elemental system is have gap insight now actually reflecting numbers of patients that are affected. So we have over 20 gaps in total of our sort of main high needs of services that aren't provided, or tasks or activities that aren't provided for high needs in Barnet. And then we've been able to go back to either community organisations, also our local ICB and public health, with those gaps and support some of the positive change that could be inputted. So, for example, AGK Barnet are now responding to one of the gaps that we've identified for the older adult population around life admin support, and they're looking for a project and commissioning for offering that now based around high need detected from social prescribing data sets as well as their own data sets as well. So just an example of how that's been supporting some positive change. I think that might be it, Jenny, but very happy to answer any questions as well, unless I hear you want to jump in.
Just quickly, since we put together these slides with regards to the neighborhood model developments, actually some GP surgeries, some PCNs have put some expression of interest for some funding using the social prescribing data and working with the team and other voluntary sector organizations. Sorry, it's not there because we put this a while ago, and this is what sort of happened the last week. Thank you
for that update. It's great to hear kind of how all the hard work to kind of get this reporting together is paying off and supporting the social prescribing services, voluntary sector, and it sounds like primary care as well. I guess to take us kind of back more towards the beginning, I'm wondering kind of what helped you develop the process for reporting, especially kind of given you're employed by Age UK, and I saw the challenges around not having the GP data. So yeah, what kind of helped?
Yeah, great question. So at the very beginning, we have a really solid steering group that have members from the Barnet Federation, as well as obviously us at Age UK Barnet, and then clinical directors and public health and ICB. So sort of having those kind of key players for discussion around what the reporting needs was had, and we work very closely. Obviously, being in Age UK Barnet, we don't have access to EMIS, and we obviously need access to EMIS for certain elements of the reporting. So we work very closely with an analyst from Barnet Federated GPs who have a system access to all 7 PCNs. So we've been lucky to have that strong relationship from the beginning. And at the very beginning, we would collab on those reports. So the bits from EMIS they would complete, and then the bits from Elemental I would complete to be able to supply the data that was necessary. And over time, we've developed that, and we now have a little bit more access to EMIS than we had, and so forth, and more discussions are being had about how we can continually improve the reporting. But at the moment, we check in with the clinical directors sort of every 6 months to see how the reporting is, if there's anything they need or want, as well as our other steering group members. And then we're obviously adapting our reporting as we go. Jenny, I think you're on mute. Yeah.
Sorry about that. There's also a question in the chat about kind of how you use ONS4 in practice. Like, is it given at kind of the first and the last session, and yeah, how do kind of the outcomes data play into this?
Yeah, I think everyone here might sympathise with my comment here on ONS, and that it is challenging to get in sometimes for that very first session, and then obviously at the very last session. So what I encourage our social prescribing team is to do it when it feels the most natural, because the conversation needs to flow. We don't want it to feel that people are being assessed all the time. It's meant to be a space for them. So usually the team will try to get it in either the first or second consultation, and then usually towards the end when you start to see some improvements made, or in that very final session. So we're not strict on that very first and last for the ONS capture, because we think the sort of flow of the conversation and the building the rapport is obviously very key to social prescribing success. So I hope that helps a little bit with that. The GP attendance is actually collected manually off EMIS, so our team do that without having to ask the client. They can see how many GP attendances they've had in that 3 month and post 3 month, so they collect that through EMIS actually. So ONS is the only one that they need to collab with the patient to complete.
Great, thank you. I think the person who asked the question has their hand up. Is it Sophia? I don't know if you want to ask anything or say anything in response to that.
Hello, yes, that was me. Thank you. I'm a social prescriber in Cambridge, and the reason why I've joined the meeting today is because we're trying, in my PCN, we're trying to measure the impact and social prescribing outcomes, as well as patients' well-being a bit better, and we're trying to figure out how it would be best to do it. So I work in a GP practice that covers a deprived community, so the activation levels are very low, and even if patients get a lot of support from us and they achieve their goals, if we ask them the question about their life satisfaction, that is part of the ONS4, they will still say no, and the overall score that ONS4 questionnaire will give us will be very low. So I'd like to ask you if you use ONS4 scores to measure the patient's well-being, or if you use the questionnaire to measure social prescribing impact and outcomes.
Yeah, it's a great question, and it is a big challenge with the questions for ONS4. So I completely hear what you're saying. And the one thing I will say is that what we made sure we do from the very early days, so I think within the first 3 months of our social prescribing service, we actually put in a feedback survey that was more highlighting the actual improvement made from social prescribing. You know, how is your well-being improved? Do you feel more connected to the social to the community that you're in? Do you feel that you've been listened to? Do you feel you've been heard? And do you feel there's been positive changes made to your situation? Are all kinds of questions in our feedback survey, because ONS4 doesn't quite capture the actual social prescribing outcome. Whereas I still feel it's an important tool to capture that kind of well-being side, and it is just a bit of a challenge with the questions and how they're formed. I would encourage, again, maybe this is something for another conversation, Jenny, because obviously ONS is something that's being highly discussed at national level, but I would encourage, you know, coming together as a team, if you work in a wider team, to discuss how you're getting around the ONS questions. And we did a lovely little workshop a year ago with our RSPs to sort of build a bit more confidence around how to ask yeah, how to help a patient understand what you're actually trying to ask, and looking at, you know, we sometimes we don't use the number rating if somebody gets confused by numbers, for instance. So you might just say low, medium, high, and somebody might respond better to that. So if there's those kind of conversations happening, it can be a useful tool to use. But I do appreciate that the questions are very specific to wellbeing, and so for social prescribing we want to have the impact of our service shown, which doesn't necessarily come out on that ONS. Or I'll stop now because we could talk about this all day.
Thank you. I think that's really helpful. I think it just shows that, you know, there's not one tool that really can capture the breadth of social prescribing impact. And, you know, we know ONS focuses on well-being, but there's other things that directly relate to what support they're being offered that could be useful as well. And it's kind of what mix of those is most useful for the service. I'll also just highlight that we are in conversations with the Office of National Statistics at the moment about the use of that measure specifically for social prescribing, and kind of, are there any adaptations or any more guidance that would be useful so people can use it a bit more confidently. And we've gathered some feedback in London around what could be useful on that. So kind of watch this space on what we might do next with that. I'm conscious we've run a bit over time, but I just wanted to kind of come to Sahir before we move on and kind of ask how kind of all this reporting is influencing public health and whether it's kind of had an impact on commissioning.
I mean, as I said, it's in terms of public health commissioning, we sort of regularly refer to the data gathered in terms of around the gaps through social prescribing. It directly informs those commissioning decisions. Because we also have a steering group which meets monthly, so ICB and the clinical directors are in the loop. So it also influences their decisions. I mean, we have kind of highlighted some of the examples here. We have these prevention funds, community innovation funding, and that goes to local voluntary sector organizations. Using the social prescribing data, we kind of try to plug the gaps in service provision, and we use that funding for the voluntary sectors to create new service or improve some of the existing services in line with the data. Does that help?
Yeah, I think that's really helpful to know kind of how the decision making is actually influenced, and that it's, you know, about the steering group coming together and kind of getting the different opinions as well as the data. It's not really this you know, it's not like some kind of AI tool that's just going to pop out, oh, you need to invest more money in this. It's kind of how the local intelligence and the different partners come together around the data and what they're experiencing. So it's really helpful. Thank you.
And thanks for the North East London presentation. I just thought that, why didn't I think about linking this data to Power BI? Hopefully next time we will be able to do that and then present some of the results. And as I think Victoria, the GP said, you know, this is a cycle. We're constantly raising more questions, ask more questions, and try to sort of address some of those things through our data analysis.